primi tentativi di ottenere un'anestesia nello spazio extradurale li troviamo nella memorabile prima esperienza del Corning, il quale nel 1885 iniettò soluzioni di cocaina nel canale vertebrale. Ma il primo che introdusse e descrisse il metodo fu in realtà Châtelain nel 1900, introducendo di fatto l'epidurale sacrale. Châtelain iniettò l'anestetico direttamente nel canale sacrale attraversando lo hiatus sacrale. Il concetto ispiratore di tale anestesia fu quello di evitare la diffusione dell'anestetico nel sacco durale, eliminando così i preoccupanti e spesso gravi problemi che seguivano alla rachianestesia sotto arachnidea. La prego.
Mi scusi, professore, ma perché oggi non utilizziamo questa metodologia?
Perché non ebbe poi fortuna nella pratica chirurgica, in quanto presentava svariate problematiche. Innanzitutto c'era la difficoltà di far risalire l'anestesia a livello lombare, per le difficoltà anatomiche ed anche per la diffusione delle soluzioni nei fori sacrali. Più tardi, Sicard e Forestier osservarono la possibilità di identificazione dello spazio epidurale a livello sacrale. Sfortunatamente poi questa pratica è risultata difficile e l'identificazione non del tutto certa. Ma oggi, nel 1934, grazie al metodo da noi proposto, metodo ormai sperimentato e largamente diffuso, noi possiamo finalmente asserire di avere completato l'opera di Châtelain, rendendo totalmente affidabile l'identificazione dello spazio epidurale a livello lombare. Buongiorno, Capogna.
Scusi il ritardo, professore.
Ritardo? Largo anticipo, direi. Più di 80 anni. Si accomodi, la prego.
Epidural block may be performed in a lateral or in a sitting position. The sitting position may be preferred, particularly for trainees or for obese women. In the lateral position, aortocaval compression is minimized, utero-placental blood flow is optimized, and there is a lower incidence of epidural vein cannulation. The parturiente is placed in the lateral position with her back at the edge of the bed, legs drawn up to her abdomen, upper arm lying across her chest, and the lower arm lying tight on the bed, with the head resting on a pillow flexed on the abdomen. The shoulders and the iliac crest should be perpendicular to the table plane. It is commonly believed that Tuffier's line, the transverse line connecting the tops of the iliac crests, intersects the spine either at the L4 spinous process or at the L4-L5 intervertebral space. However, full-term parturient women undergo various physical changes, and determining the vertebral level with Tuffier's line based on palpation may not be very accurate. Vertebral levels are more cephalad in parturient women as compared to non-parturient women, and this should be taken into account when performing an epidural block in term pregnant women. Since the epidural space is widest at L2-L3, and the spinal cord usually ends at L1 but may extend to L2, mid-lumbar interspaces are usually selected. Evidence on ultrasound-guided identification of the epidural space in pregnancy is still limited, and in obstetrics this technique is not commonly used as a routine tool for detecting the epidural space. Prepuncture ultrasound may be performed to find the midline and the interspinous space in order to mark the position of each on the skin. The depth of the epidural space may also be determined by using the ultrasound scan. Epidural block is eventually performed in the usual way, with the skin markings as an additional guide. After passing through the skin and subcutaneous tissue, the needle should move through the supraspinous and intraspinous ligaments, and finally the ligamentum flavum. The ligamentum flavum is one of the main ligaments supporting the static and dynamic functions of the vertebral column. It consists mainly of yellow elastic fibres. It inserts on the superior edge and posterior-superior surface of the caudal vertebrae and the inferior edge and antero-inferior surface of the cranial vertebrae. Embryologically, it is a paired structure that fuses in the midline, and the degree of midline fusion may vary between individuals. When the needle is in the perfect midline ligamentum flavum, it may not be perceptible as a barrier to the epidural space. Posteriorly, the ligamentum flavum is bordered by the spinous muscles, and in the midline by the interspinal ligament. Anteriorly, it is bordered by a mixture of afti and very loose connective tissue. Lumbar epidural fat has a metameric and discontinuous topography. It is mainly located in the posterior aspect of the epidural space, which is in part real and in part virtual. The epidural fat extends in the craniocaudal direction from the lower aspect of one vertebral lamina to the upper portion of the lamina of the next caudal vertebra, and in the lateral direction towards the point where the articular facets and the ligamentum flavum meet. It also fills the space between the vertebral arches and the intervertebral foramina, wrapping the nerve root cuffs. The volume of the posterior epidural fat is uniformly distributed and increases caudally from L1-L2 to L4-L5, so the tip of the epidural needle crosses a real space during the performance of the anesthetic technique. Several spinous processes and interspaces should be palpated to determine the widest interspace and the possible presence of scoliosis or vertebral column deviations. The index finger and the middle finger of the non-dominant hand are placed parallel to the spine, indicating the interspace chosen. These are the so-called landmark fingers. They facilitate the proper placement of the needle in the center of the interspinous space and will indicate the landmark for the Tohohi needle insertion. The fingers should be kept in place until the Tohohi needle reaches the next landmark, which is the ligamentum flavum. The angle of penetration of local anesthesia infiltration should be the same as that for the epidural needle. The epidural needle is held with the palm of the hand resting on the hub and the shaft of the needle between the fingers of the dominant hand. Without moving the landmark fingers, the epidural Tohohi needle is inserted exactly in the middle of the interspace through the previously made skin wheel. Once inserted into the skin, the epidural needle should be advanced, taking care to remain in the midline. The needle must be advanced very slowly, but constantly without any interruption, in order to be able to recognize the different densities of the underlying tissues during its advancement. As soon as it reaches the supraspinous ligament, a resistance is encountered due to the nature of the bevel and the density of the ligament. The needle is then advanced through the loose interspinous ligament, which offers much less resistance than the supraspinous ligament, often felt as a no-resistance feeling in the obstetric patient, until the point of the needle is felt to meet the third and greater point of resistance, the ligamentum flavum. This feeling of a greater increase of resistance is often associated with a crunch that indicates the initial penetration of the needle into the rear wall of the ligamentum flavum. Instead, if the resistance is absolute, the bevel of the needle may be against the bony vertebral arch. And any attempt to force the needle may result in the patient experiencing pain due to periosteum stimulation. In this case, the needle should be withdrawn, its angle of inclination checked, and the direction changed accordingly. As soon as the point of the needle has engaged the ligamentum flavum, the advancement of the needle must immediately be stopped, and the hands of the operator must change their initial position. The back of the non-dominant hand rests firmly against the patient's back to prevent advancement as the needle enters the epidural space. with the hub of the needle grasped between the thumb and index fingers. The dominant hand removes the stylet and gently attaches a disposable 10 milliliter loss of resistance syringe containing a few milliliter of sterile saline solution to the needle. Constant, unremitting pressure is now exerted on the plunger of the syringe by the thumb of the dominant hand, and since the saline content of the syringe is incompressible, the syringe and needle advance together solely by means of the pressure exerted by the operator on the plunger of the syringe. For as long as the needle point remains within the ligamentum flavum, there is a great resistance to injection, and the pressure exerted by the thumb on the plunger causes the advancement of the needle. As the point of the needle emerges from the ligamentum flavum into the epidural space, the resistance suddenly disappears, and the advancement of the needle immediately stops, since the driving force exerted on the piston is discharged by the sudden entering of the liquid into the epidural space. When the epidural needle is positioned in the epidural space, the syringe is removed, and the needle observed for the appearance of spinal fluid. A few drops of syringe solution may leak from the needle. After negative aspiration for blood or cerebrospinal fluid, proper placement of the needle may be further checked using the air or rebound test. A very small amount of air is drawn into the loss of resistance syringe and attached to the needle, and the plunger of the syringe is tapped sharply. A positive test results when the syringe collapses and does not refill at all. If the plunger rebounds, a partially inserted bevel of the needle in the epidural space could be suspected. Combined spinal epidural block is becoming an increasingly popular technique for initiating pain relief in labour or for achieving effective anaesthesia for caesarean delivery, with some units using it as their standard technique and others using it according to clinical circumstances. The most commonly used technique in clinical practice is the needle-through-needle technique. A minimum of 13 millimeters length of spinal needle protrusion beyond the epidural needle tip is recommended for the CSEA sets to achieve a reasonably high success rate. Some kits include spinal needles which allow fixation to the epidural needle in order to reduce the risk of spinal needle displacement during intrathecal injection, with the subsequent risk of failure of spinal anesthesia. Using this technique, the epidural space is located in the normal way with an epidural needle. An extra long, 25G or smaller, spinal needle is then passed through the epidural needle to puncture the dura. The epidural needle thus effectively acts as an introducer. Usually, a characteristic dural click is felt, and CSF seen in the hub of the spinal needle. An intrathecal injection is then performed, after which the spinal needle is withdrawn and an epidural catheter is threaded down the epidural needle into the epidural space. Once the needle is in place, the epidural catheter is advanced through the needle by the dominant hand, while the back of the non-dominant hand is kept resting firmly against the patient's back, with the hub of the needle grasped between the thumb and index fingers. The parturient should be warned that she might feel an intense tingle in her hip or legs when the catheter is advanced a few centimetres beyond the bevel. The needle is removed. This is an important manoeuvre, since the catheter may be dislodged from the epidural space while removing the needle. The dominant hand should attempt to advance the catheter while the non-dominant hand is pulling out the needle. At the end of the procedure, the catheter distance marks are checked and the catheter properly positioned. The catheter should be aspirated with a 2 or 5 milliliter empty syringe in order to detect blood or cerebrospinal fluid, which are, respectively, signs of accidental intravascular or subarachnoid placement of the catheter. Placement of the catheter more than 5 centimeters into the lumbar epidural space may be associated with a higher incidence of unilateral block and a greater likelihood of the tip entering an epidural blood vessel. On the other hand, Too little catheter length leads to a risk of the catheter falling out. The catheter is then secured with tape and adhesive dressings and used for the intended purpose.
Vi esorto quindi a praticarla, poiché, come disse Aristotele, noi siamo ciò che facciamo ripetutamente. L'eccellenza non è un atto, ma un'abitudine. Grazie.
Arrivederci, professore.
Arrivederci.